All right, so without further ado, it's my honor to introduce our moderator this afternoon, Dr. Stephen Frank, professor and deputy head, radiation oncology, medical director of the Proton Therapy Center at the UT MD Anderson Cancer Center. Dr. Frank.
Thank you, Steve, and welcome everyone today for the Industry Expert Theater. I have the opportunity and want to thank Augmenix for the opportunity to be the moderator for this session. We've got a robust group of experts, and our first speaker today is going to be Dr. Michael Zaleski, professor of radiation oncology, vice chair for the Department of Radiation Oncology, and chief of brachytherapy service at the Memorial Sloan Kettering Cancer Center. He's going to be speaking on broadened role for SpaceOAR in the radiotherapeutic management of prostate cancer. After he speaks, we will be moving on to the two additional speakers. Please write your questions down, and once the three speakers are done, we will then take question and answer sessions at the end. Thank you.
Thank you very much, Dr. Frank. And what I'm going to be speaking about is, as we move from the very important randomized trial demonstrating the efficacy and benefit of using hydrogel spacer, even in the setting of conventionally fractionated external beam radiation, there's potential and important role for the utilization of spacer beyond conventional fractionation as well, which we'll talk about. And here are my disclosures. I'm a consultant for Augmenix and serve as the editor-in-chief of the Brachytherapy Journal. So the question comes up, is post-radiotherapy rectal bleeding a clinical concern in 2018? And that's really been the focus for many people who have raised the question, is a hydrogel spacer important? Because some would say that really there are no issues in terms of rectal bleeding, and what do we need to spare more of the rectum if our technology has been advanced to such a point where toxicity is no longer an issue. And that's not really the case as our field is moving towards more intensive dose escalation regimens, as we all know. Here are the moderate hypofractionated external beam trials. And if you just look at the toxicity outcomes, again, in all of these very important trials, from CHIP, Hyproprofit, and the RTOG, you can see that as we talk about late grade 2 rectal toxicity here, it's either 14 versus 12, 18 versus 22. We're seeing most of these in double-digit numbers, indicating that with moderate hypofractionation, there is a concern regarding grade 2 rectal toxicity. True, not grade 3 or 4 as much, but this certainly impacts upon quality of life. And these important trials are ongoing where we are exploring beyond moderate hypofractionated regimens to ultra hypofractionated regimens. And again, this may be even more of an issue. And then the other approach is regarding the ASCEND-RT trial, where there is recognition, mostly recognition, I would say, in the field, that the combination of utilizing brachytherapy in conjunction with external beam radiation for higher risk patients, unfavorable, intermediate, or in this case, there was a 2-to-1 spread for higher risk patients in this ASCEND-RT trial. And here we have that with dose intensification, a combination of external beam radiation and brachytherapy, that achieved a significant and important PSA relapse-free survival at 9 years with the dose intensification of brachytherapy combined with external beam radiation versus radiation alone. And a concern that has been raised about this trial is the fact that the grade 2 and even grade 3 rectal toxicity is not to be dismissed. Older patients, techniques have changed in the meantime, but this very important level 1 evidence has been criticized because of the concerns for rectal toxicity. And so this extremely important trial that was updated with longer follow-up by Dan Hamstra as a level 1 evidence that when we use conventionally fractionated external beam radiation with a 2-to-1 randomization between using the spacer and fiducial markers versus just fiducial markers, in other words, external beam alone versus external beam plus the spacer. And in this important study, when looking at the percentage of patients who had impact on their bowel function based on quality of life data and even based on toxicity, physician-reported toxicity data as well, there was a significant improvement or reduction in toxicity for those patients who had spacer compared to those, the control, who just had the fiducial markers alone. This was again for patients treated with conventionally fractionated external beam radiation. And as you look at these curves, especially talking about rectal, grade 2 rectal toxicities, we see a significant improvement at the 3-year point for patients who had the spacer compared to those who didn't have spacer. So clearly we have clinical evidence that even in a group of patients who we didn't think had too much toxicity to begin with, there was still an improvement when it comes to utilizing a spacer in this cohort of patients. And here, as part of that study that was reported, interestingly, when looking at the 36-month time point, it wasn't only bowel that was significant in terms in a multivariate analysis, but also, as we see very clearly, urinary side effects were also reduced with the utilization of that spacer, which I think we can talk about as far as reasons or speculate why actually that is the case. And so with that very important level 1 evidence from Hamstra et al., we have utilized spacer, in particular in our experience and at our institution, for the SBRT population, for moderate hypofractionated regimens, for dose intensification when we combine external beam radiotherapy with brachytherapy, which has been shown to achieve improved disease relapse-free survival rates when you use that dose intensification. And we have more of a confidence of delivering lower rectal doses with the placement of the spacer. And here are these opportunities: combination of external beam fractionated IMRT or SBRT alone as ultra hypofractionated, or even in cases of selected cases of salvage brachytherapy, where we are now recognizing, urologists have always said, you can't get external beam radiation because if you get it, we can't salvage you. But now we have opportunities to salvage patients even when they fail radiotherapy, but we need methods, we need tools to be able to deliver this in a safe fashion. So here's an illustration of the spacer utilized after seed implant, which protects basically the rectum from the indwelling seeds. And one of our former fellows, who's now in Sunnybrook, Aman Tagar, reported this in Brachytherapy 2017. Of 79 patients who underwent brachytherapy and had spacer placement, combination of either monotherapy or combination therapy, and there was clearly dosimetric improvement. That's not terribly surprising, achieving that separation with an average of 1 to 1.2 cm separation achieved a reduction in the volume of rectum exposed to the high dose. And when we compared a group of patients who had spacer compared to those that didn't have spacer contemporaneously at the time, there was significant dosimetric improvements among patients who had the spacer compared to those who didn't have the spacer in a brachytherapy cohort monotherapy patient population. And when we look overall at our toxicity rates, minimal toxicity rates, or at least on the low side, if anything, lower than what you would expect in terms of GI toxicity in particular. When it comes to SBRT, our experience has been that we have initiated and completed a dose escalation study where we moved from 32.5 gray to 40 gray ultimately. And initially in November 2015, when hydrogel spacer placement became a reality and approved, we started using that. And we have treated just with SBRT alone now close to over 300 patients for SBRT monotherapy treated along with a rectal spacer. And what we see clearly when we compare that to a cohort of patients sequentially prior to our utilization of the spacer, there was once again improvement in dosimetric outcomes for those patients who had the spacer, basically in terms of the rectal dosimetry from whatever we were looking at based on the rectal V50, the V20, or the V50 exposed to the prescription dose. There were all significant improvements compared to those patients who didn't have the spacer. And overall toxicity as far as grade 2 GI, rectal bleeding, in this case was 0.7%. Hematuria was also extremely low, consistent with some of the observations that were made in the randomized trial. And again, you can see here how easy this would be in terms of planning a combination therapy when the isodose curves are really wrapping away from the rectal area, as you can see here clearly. So overall, we've treated about 800 patients with the hydrogel spacer placement. We've not observed any significant toxicities associated with the placement itself. Actually, in one case where there was a salvage procedure with extreme high fibrosis in the area away from a prior seed implant, this caused a ulceration of the rectal mucosa, which was one out of these out of this group of patients. And I would say that you need to exercise a good deal of caution, I think, still in the setting of previously treated patients. 10% experienced some rectal fullness as acute symptoms, mild perineal discomfort for 24 to 48 hours, addressed or ameliorated by anti-inflammatories. Other areas which this could be potentially beneficial, we've talked about the salvage radiotherapy as well. And I've treated more than I've done before, although with a good deal of caution, the patients who have a history of inflammatory bowel disease, because if we could completely avoid or significantly avoid the volume of rectum exposed to those doses, it's an option for the patient as well. Still, we would tell them of the potential risks associated with that. So, in conclusion, dose intensification has been shown to be important for the treatment of high-risk disease, yet treatment-related morbidity may develop. And that's been a concern that's been raised regarding the ASCEND-RT trial and the even utilization of SBRT as monotherapy. Hydrogel spacer consistently helps facilitate significant reduction of the rectal doses of ultra-hypofractionated regimens, as well as with combination therapies, which I think are important ways of treating high-risk patients. It's one of our best tools as far as dose intensification. Hydrogel spacers should be done with caution, or probably not done for those patients who have suggestion of disease posteriorly on MRI as posterior extracapsular extension. Early results demonstrate minimal late toxicities, and the mere reduction of the volume of rectum exposed to high doses, which has been used as a reason to adapt proton therapy to reduce the risk of secondary cancers, may be an additional reason that we could see in the next 10 years if we effectively and consistently reduce the volume of rectum exposed to our high doses. Thank you very much.
So thank you, Dr. Zaleski, for that outstanding talk. I did want to just mention, if anyone is having difficulty hearing, please raise your hand. Okay, so it's working. And also, I wanted to first also thank Boston Scientific, who is sponsoring this industry expert theater. This session is being recorded and is available to you on the ASTRO website. We do have a speaker, if you can't hear us, please just again raise your hand and we will switch out your headphones. Our next speaker is Dr. Marcio Fagundes, Medical Director, Radiation Oncology Department at Miami Cancer Institute. He's going to be speaking on achieving consistent prostate rectum sparing in large and small prostate glands with the hydrogel spacer. Dr. Fagundes.
Okay, thank you so much for the introduction, Steve. So my goal today is to address, some of the challenges that we face and how to overcome them, but also I want to drive a message because this was my reality starting this procedure when the product was first launched, is that I worked in an outpatient facility, not a hospital base, so I didn't have the luxury of doing the procedure in the OR. So when I started into this day, now working in a different facility, I'm doing this as an outpatient. So this is the title. My disclosure is a consultant to help new users with Augmenix over the years, and now Boston Scientific to learn the procedure. So basically, this is what we've seen, right? We're doing a transperineal placement of the hydrogel, and this gets reabsorbed after a few months. So currently, for the past 2 years, I've been working as medical director of the Miami Cancer Institute Radiation Oncology Department, and there we have all of the technologies available for treatment of patients with IMRT, tomotherapy, MR-Linac, protons brachytherapy, and we are basically using this product with any modality that we see fit for the patient. So as a startup, I think I want to go over how we did this, and basically it was April 1st that the product was approved, and the subsequent week we did the first 4 cases with Augmenix present. We chose to do Valium hydrocodone as pre-medication, EMLA cream on the skin, place the fiducial markers first. This is how basically the patients are numbed. I had been doing fiducial markers for at least 2 years with this technique of numbing, so it was quite straightforward to add gel. So basically, with gel, we're numbing the midline of the patient with a single stick at midline, and then angling the needle to the right apex and left apex and numbing right up against the capsule. It's about 10 cc's of lidocaine. So this is a video that shows the needle coming in and numbing the path. This is at midline. It's going to approach the apex. I'm going to show you just the midline here in the interest of time. And this is what we're numbing here. And then we angle to go to the corners. Now, this is very important. As I said, this is all done as an outpatient local numbing. The pre-medication that we use, Valium hydrocodone, antibiotic, the EMLA cream on the skin, lidocaine interstitially. And distracting the patient is extremely important because it helps keep their mind off of what we are doing, and it makes the procedure seamless. And I think that whenever necessary, we should use extreme measures, even if we have to go this far. Now, in case you think that this is not real, I'm going to ask Rebecca and Lindsay to stand up because they are right here. See, this is real. Okay, let's continue. So basically, here's how we see the patient as we're standing and doing the procedure. Placing the needle, we're going down this path as we do the placement of the gel needle. It's extremely important to have your ultrasound set right at midline sagittal, not too high, compressing the prostate, not too low, so you create too much space. The gel could pool in one area and not dissipate. You want to have equal disbursement of the gel. You want to have your needle at midline so you don't get asymmetry. So basically how this goes is, this is a Hydra Dissection. I'm coming in with a needle now into that space just behind the fascia in front of the rectum. You can follow the needle in the mid-gland right here. You see how fast that is in the mid-gland. Do you inject saline? In the beginning, I used to use more saline. I'm using less saline. And once I find the space, I'm comfortable. That's it. Now we're going to the gel injection. The needle is again, in this case, at mid-gland. As the injection starts, the gel is going to dissipate towards the base, and it's going to backflow towards the apex. As you can see, it's lifting the prostate and pushing the rectum away. Now, before I started, I had the luxury to read this paper. And this is basically talking about a learning curve of the first 15 cases of this Dr. Pinkawa, this user, who then realized that he could improve his symmetry, and by improving the symmetry of the gel, improve the V70 sparing, reducing the V70 from 6% down to 2%. And I paid a lot of attention to this, and I said, you know, I can probably make sure that I don't have this degree of asymmetry if I just follow basic principles. So to me, it was obvious that I had to, once I get the needle under the prostate mid-gland, go back to axial view and make sure that the needle is midline. But secondly, give a puff or two, a cc, a half cc of saline, and just make sure the saline is dissipating symmetrically, because this will guarantee the gel is symmetrical as well. So you don't end up with this scenario. So you are here. So how does this look on the ultrasound? Basically, this is another video. You see the needle right there. The needle is showing the gel. See the gel, the saline. As you do a puff of saline, you see the saline dissipates. The other thing you can see here is the needle. The needle tip moves freely, so it's not in the fascia or in the rectal wall. So what happened to our first 4 cases? Here they are. As was already pointed out by my colleagues, you don't need perfect symmetry to get excellent sparing of the rectum. Look at these first 4 cases. The V70s were less than 1%. They're not all perfectly symmetrical, but very good results. Now, this is a very interesting case. Oh, before I go there, we did this for the first 4 cases. We did an immediate same-day MRI. We had the MRI next door. We had a luxury to do it. So we did the MRI and we reviewed the results. And then we went on to do the next case and the next case. And that was very reassuring that we were getting what we wanted to. And then from there on, we just did the planning MRI on day 3 to 5. Another tip is we use fiducial markers that are visible on MR. So you use MR, CT, fiducial-based fusion, which will give you better, more accurate fusion when you're going to contour the hydrogel and contour the prostate. So if you do that, it's going to help. So now we're on our very first patient. This is an interesting story, not just because the patient is the urologist, just retired the month prior, but also because he understood that the hydrogel was imminently now being released by the FDA, and I had told him about it, and he said, you know, let's wait a month or so, and then we can do that. And then it was delayed a little bit, a month, and then he said, well, let's start the treatment with balloon, that's fine. So we went ahead and did the plan with the balloon, and then the gel came out the following week. I called him back and said, let's do gel then, and he said, yes, I do want to do that. So we had the CT that we did before we placed the gel, and then the planning CT. And now we have the same patient planned with balloon, empty rectum, and hydrogel, and its V70 was 0 compared to 8.7 and 10%. So clearly a dosimetric advantage in the same patient. Now, let's talk about some technical aspects that will help anyone do this for the ones that are starting and maybe the ones that are already doing that you could pay attention to. So this is the axial view that I told you. Once you reach mid-gland on the sagittal plane, you go to axial and check your needle. Move your needle up and down, just wiggle it gently. You see how the rectal wall is just caught, the outer layer of the rectal wall is caught right there. When you move the needle, you can actually see the rectal wall being pulled. So this is easy to fix. You just pull the needle back towards the apex, not all the way out. Bring it up just a millimeter or 2 and insert it back in. Make sure you're not going into the prostate as you do that. That's all you do. Now you go back to axial, check again. And I do this 2 or 3 times, checking things on axial. See, now the needle is free. And this case turned out perfect. Can we do this on patients with prior procedures? Already mentioned, yes. This was our 5th case. A patient that had a TURP, anal fissure surgery, and history of hemorrhoids. We definitely didn't want to radiate this patient's rectum. So despite all the scarring that he had, we were still able to get reasonably good separation, not a lot of disbursement left and right, but in the end, we had very good dosimetry. His V70 was 0.3%. And as you can see in this graph, the rectal histogram here, the 70 is essentially 0. So can we use this in the retreatment setting. Yes, this is a good case to illustrate. A patient that had rectal cancer treated in 2007 with 50.4 gray with chemotherapy and went on to have surgery. But you look at the location of his prostate and the rectum that was radiated. Basically, his prostate rectum interface was treated to 50/40. And many years later, 9 years later, he developed a prostate cancer, not a suitable candidate to surgery or brachytherapy, given his urinary symptoms and so on. So he said, well, maybe we should do this with external beam. If we can get gel separating the rectum from the prostate, we can do it safely. We were able to place the gel very well, disperse it base to apex, left to right. And you can see here the suture line of his surgery from the past. Here's his dose distribution. And his V70 actually turned out that it was 0. The V50 was only 0.25. So excellent gel placement allowed us to retreat this patient. My concern was, is this stable? Is it going to stay in the same thickness over treatment time? So I did another MRI at the 6th week mark just to be sure, and the gel was absolutely unchanged. So perfect stability of the gel throughout the treatment course. Now, to address another point, this will be important in larger glands. So a large gland is the same thing as having the probe too high. You compress the space between the prostate and the rectum, and you limit the amount of space you have to place the gel. So this is an illustration of how to do large glands that were not included in the pivotal trial. This is a patient with 170 gram prostate. So what I would recommend in these cases is use a standoff balloon to see the interface between the rectum and the prostate, which I did here. Now the square is where the landing zone is for the needle, and the black line is the saline in the standoff balloon. Now I deflated the balloon to allow space for the needle to come in. So you have to deflate the balloon to create more space. So here's the needle coming in. You see this prostate is huge. It barely fits in the field of view of the ultrasound. So it's very limited space, but still very doable. You just have to keep hugging that fascia. Now the key thing here is, as you begin to hydrodissect, you open the space. Immediately when you open the space, you should advance the needle bit by bit while the space is still open, because with the weight of the prostate and the size, it will collapse the space. And so when you open it, you advance the needle. And now you can see here, this is important. When you hydrodissect, you have to have the needle midline and make sure the saline is dispersing left and right. Otherwise, the gel will become asymmetrical. But see how the saline is basically compressed away from there? You have to inject this gel slower, not as fast as usual case. Otherwise, it just flows laterally and doesn't stay under the prostate. But look at what happened with this patient. 176 gram prostate, 1 centimeter separation, V70 of 0.79. So good space, excellent symmetry, exceptional rectal sparing. Another challenge that can happen is this. Now, this is a relatively small prostate, but look at what the challenge really is. The urethra is very low and it doesn't come up anterior like this, but it's rather horizontal. So where's your needle coming in? Right here. Now you're doing this under local. The patient is awake. The urethra is not numb. So you cannot nick the urethra. You have to come under the urethra and make your way over the hump and under the fascia. So we did this patient without any problems, just took a little bit more finesse. So you'll find this scenario. I showed this because I've only seen it 4 or 5 times now. It's about 1% of my cases, but this is what it's going to look like. So this is a patient that had scar from a biopsy that caused a lot of infection, bad infection, and it scarred the tissue. There's no way to predict this on MRI. But you bring him to do the procedure, and very rarely you will see this. The needle, you're trying to get the needle in, but it just pushes the tissue away. There's a lot of fibrosis here. The needle just doesn't make its way in very easily. But eventually I made it to mid-gland. While in mid-gland, I tried to see, well, let me see if I can hydrodissect now. And as you'll see now, looking at the tip of the needle, the saline barely comes out of the needle. There's a lot of resistance. So at that point, after trying multiple maneuvers, I decided to abort the case and not do the hydrodissection, not to place the gel under force, because that's not what we should be doing. So after this case, I came up with this algorithm, which I had in my head, but since there's more than one user in my center now, I had to have this in a document form. Basically, if a patient has prior conditions like anorectal fissures, stenosis, rectal surgery, a big prostate, I'll check the box eligible, but potentially increase technical difficulties. If the patient has no history, it's eligible without any preconditions. If the patient has posterior extension through the capsule towards the rectum, we'll check the box as ineligible. So this also serves the purpose of us recording the fact that we have to check on blood thinners and all other aspects that will be pertinent at the time of the procedure. So I want to show this short clip. This is really interesting. This is from our MR-Linac device. And what this is basically showing is the blue is the prostate. The red is a 3 millimeter boundary, which is used to trigger the beam on or off if the prostate moves. And the white is the hydrogel behind the prostate. So the beam is only on if the prostate is within the red. And here's the delivery, just a piece of the delivery. This is an SBRT 5-fraction case. And what you can see is that the patient is breathing. There is minimal motion, the bladder here, the sigmoid, but the prostate and the rectum are really not moving. And this patient was treated with 5 fractions, and there was only one instance that the beam was held for a few seconds. So there's very good intrafraction stability as you're doing these. So this is what, my experience is over the years now, is that on weekly checkups and follow-up visits, patients and their rectums are truly happy. And, they really don't have complaints. So as far as what we do today and what we did before for disclosure at the Provision Center in Knoxville, where I started, we use rectal spacer for any patient that is a candidate, which most of them are, as the new best standard with any of the modalities, IMRT, SBRT, or protons. All procedures are done as an outpatient. Takes 15-20 minutes. This is important. I actually pulled back on using benzodiazepines and Valium. I'm really giving patients Tylenol, Emla cream on the skin, and local numbing, and that's basically it. No longer using hydrocodone and benzodiazepine. Larger prostates, greater than 80 cc's, not included in the trial, are suitable candidates to do this procedure, and you should get similar V70s of 1 to 2%, similar to smaller glands. You may have to do some technical adjustments to optimize the results in these patients, like slower injection, as I described, and a few others that we can talk offline. And I think this is really important, is that I feel more compelled to use rectal spacer in patients that are on chronic blood thinners, because they are particularly at risk, if they have injury, to have rectal bleeding. So we really want to prevent rectal injury. SpaceOAR is preferred over endorectal balloon or empty rectum, in my opinion, to improve rectal sparing. And obviously extracapsular extension is only a contraindication to be considered for posteriorly located infiltration. If the infiltration is lateral or anterior, I think is a moot point. I think it's really important to have good equipment, good image quality for success of the procedure. Team approach, MDs, dosimetry, physics, nursing, medical assistant engagement, and don't underestimate the importance of distraction. Do not underestimate. Thank you very much.